is Christy. We're at St. John's. Christy's one of our lead therapists. She also teaches our joint replacement class. And nowadays, most patients, usually within the first 24 hours, have switched to a cane. And so I just wanted Christy to just go over the mechanics of how to use a cane so that patients can prepare themselves prior to surgery. Go ahead, Christy.
Okay, so to be effective with the cane, you need to be able to tolerate, say, 90 to 100% of your weight on your operated side. The cane itself is not designed to take weight off like a walker is. So if you're going to effectively use a cane, you need to make sure that you're walking well without the walker, as in not having to put any weight through your hands. Okay. Now, when we're going
Christy, who makes that decision? Is the therapist, is it the physician, or is it the patient about when they're ready to go from walker to a cane?
A lot of the times it's the patient. However, if you're still limping a lot and we're seeing that you're limping, despite the fact that you're not maybe putting weight through your hands on the walker, we may coach you to actually put a little bit more weight through your hands so that you're eliminating the limp. We don't want you to limp at all. So, but at the same time, if you're just walking around the house and you notice that you're not putting pressure on your hands and you're not limping, it's time to get rid of the walker. It becomes more of a crutch than a helpful aid or assistive device at that point.
Good, that makes sense.
Okay. Now, when you're transitioning to the cane, the most important thing is knowing what side of the body to hold it on. It's the most common mistake we see with anyone who's using a cane, and it's something that's very easily correctable. So the biggest thing is making sure you're holding the cane on the opposite side of pain or the opposite side of surgery. So if I had a left-sided hip or knee replacement, I'm going to be holding the cane on my right side. Okay. Now, if I'm left-handed, this is going to feel really awkward at first. But you're going to have to just train your brain to teach your body to knowing that this is the correct way to do it. It's much more harmful to hold it on the wrong side. And if you're trying to learn to walk correctly after you went through all the surgery and therapy and training and things like that, it's worth it to just keep working and basically practicing with it until you get comfortable. Okay? So if this is my operated side, I'm going to hold my cane on the opposite side. Okay, and sequencing with the cane is very similar to the walker in the sense that you're going to be putting your cane forward first, then your operated side, good side. Okay, so you're weight shifting, but you're not putting weight on the cane. It's just there for balance. So cane forward first, operated side, good side. Once you get that down, then we're going to start to encourage you to take equal stride widths on each leg. So the difference with that is you're going to be hitting the cane on the floor at the same time as your operated side. So it actually acts as kind of like another leg as you're walking on that foot. So then you're going to bring the cane, your operated foot forward, and then swing through with your good side. Cane with your operated foot forward, and then swing through with your good side. Okay? For most people, this is the hardest part to kind of get down because it can be a little bit awkward or it just feels like they don't have enough support. So that's when we'll be there coaching you, or we can, make sure we have a hand on you to make you feel a little bit more secure. We won't change you to the cane if we don't think you're ready. Okay?
Christy, can I ask you? Yeah, everybody knows. Well, it's counterintuitive. Why do we put it on the opposite side?
So, natural human anatomical walking is opposite arm, opposite leg. Okay? If you're putting the cane in your other hand in order to be able to lean on it, you're actually then walking completely wrong. Our bodies were not designed to walk like this. Okay, so we're promoting correct anatomical alignment. Again, just like since you have a new joint, everything's in a new anatomical alignment, we want it to be correct. Okay, and the other thing about that is if this is your painful side, and you're actually leaning towards your painful side if you're putting the cane on that side for support. So that's then becomes more of a crutch. You're hurting yourself more by doing it that way. So putting the cane on the opposite side gives you a chance to take some of the weight away from that side so that you're not actually pushing more towards it and you're promoting correct anatomical walking.
That's a great visual explanation. Let's go back. It seems like there's two stages. Stage one, where you're going almost a 3-point gait where it's cane foot, operative leg, cane foot. Can you go through that and then go to stage two again?
Mm-hmm. So when you're just working on the mechanics of feeling comfortable in order to put all of your weight on your operated side, we break it down into simple 3-step walking. It's easier for you to get the hang of it first, and then after that you can start to go a little bit quicker and more normally. So cane forward first, operated side, you're just matching the cane at this point, and then good side. Okay, cane forward first, operated side, and then good side. Once you get that hang of that body weight shifting, and you're comfortable with being able to use the cane in the opposite side of surgery, then you're going to try to hit the cane at the same time as your operated foot and swing all the way through with your good foot. Okay, so again, this is acting as another leg, a little bit of support for that side for balance. Okay, so operated foot with the cane, and then swing through with your good side. So, and then after that, once you get the hang of it, you should be able to just walk normally with the cane.
Yeah, and I know this is all very mechanically detailed, but I've seen a lot of patients transition from the 3-point gait to that more normal gait within 15 minutes of instruction.
Oh yeah, sometimes I don't even have to coach them, they just do it automatically.
But they shouldn't skip over that step, but sometimes people won't need more than 5 to 10 minutes of training through that step.
Right.
That's great. And is this something they should practice at home, or is this something that they just do in the hospital?
I mean, I think it's a great idea, especially with the cane, because for some people, being in the habit of using the cane in their non-dominant hand takes a lot longer than just a day or two in the hospital. So if you can get a cane prior to surgery, you can practice walking with it on the side that it's going to need to be held on for surgery, it makes that transition so much easier.
Great. I have 2 more questions about the cane. So that's a pretty standard cane. A lot of patients ask us about the 3-pronged or 4-pronged cane. Does any of that make a difference?
It does make a difference. So for orthopedic surgeries, especially if you weren't using anything prior to surgery, you don't have any past medical history of the need to use a 4-prong cane, a single point cane is going to be the most effective and make you the most mobile because it's designed to hopefully get you off of it. Something like a 4-prong cane is designed to hold more weight, like something like a walker or a hemi walker. They're designed for people who have had neurological deficits like a stroke or a brain injury or something like that. It's way too heavy duty for someone who's not going to be using it for that.
So neuromuscular issues like Parkinson's or prior stroke or some other multi-joint comorbidity, but everybody else should just be using a regular cane.
Right. It's more, a 4-prong cane is for someone who like maybe can't use the other hand on a walker because they had a stroke and they're contracted this way.
Okay, so, and 2 questions, very detailed, just about what's the right height for the cane?
So the height for the cane and the walker, in theory, they should be the same height. So it's based on basically 2 things. It's going to be based on your leg height and your arm height. You're looking for a 30-degree bend in the elbow. So for most people, that's around the wrist joint area. If you're looking at wrist joint, on me, it's my wrist joint, so that you have a nice 30-degree bend in the elbow. Okay? If you have really long arms or if you have shorter arms, you may need to go to like your hip bone so that you still get enough support there. So it varies slightly on person to person.
Is there a priority? Do you want to match the hip height or do you want to match the arm height?
We're looking more for arm height. We want to have that 30-degree bend in the elbow.
And it's typically at the level of the wrist?
Generally speaking, yeah.
That's
You don't want to be holding the cane way up here, but if it's too far, then you end up bending over and we don't want that.
And again, very detailed. So the cane has a little hook in it, and which way do you put the hook?
So, I mean, I've seen patients walk with it this way, but it's not ergonomic and it doesn't really give you support here. So if you're facing a hook away from you, then it fits very well in your hand and it actually gives you a little bit more support there. So there are canes that don't have a bend in it at all, it's just a straight cane, and those are fine too as long as the handle fits in your hand okay. So.
Wow, terrific. Thank you, Christy.